For our final panel, we have 5 distinguished guests from 5 different professional associations, medical associations, that we'll hear from, panelists that are going to be joining us. We have Dr. Bobby Mukkamala, immediate past president of the American Medical Association, Dr. Robert, I tried to pronounce the name, Piccinni? Piccinni, sorry. Immediate past president of the American Osteopathic Association, Dr. Mark Rapaport, president of the American Psychiatric Association, Dr. Stephen Taylor, president of the American Society of Addiction Medicine, and Dr. Arthur Evans, CEO of the American Psychological Association. Again, I thank you all for bringing your expertise here. It's really exciting to see the representation in the crowd and in the panels from the federal side, the payer side, the association side, the stakeholder side. I mean, this is really kind of plants a flag on recognizing that, I think we're coming together as a nation to address the problems and the mental care situations that we're having. Each of you brings a perspective of clinicians to the folks that are providing care to the patients that we see on a daily basis in our communities. And your organizations represent a spectrum of clinicians working across these settings from primary care to highly specialized psychiatric and addiction treatment. Each of you as clinicians and as representatives of your respective organizations have been on the front lines working to navigate the myriad challenges that we all have seen facing and struggling with mental illness and addiction. I would like to turn to a couple of questions. I'm going to start. Curious from the AMA and the AOA's perspective, particularly from the vantage of primary care. We know that primary care settings are going to be critical to addressing the addiction and behavioral health treatment gap in the country, and that having more specialists just isn't going to be the answer. How are you working through your members and through your partnerships with organizations like the APAs and ASAM and others to help build capacity among the general medical providers to treat addiction and behavioral health issues and to support long-term recovery? I'll start with you, Dr. Mukkamala.
Thanks, Tim. It's great to be here. Already learned so much in panels 1 and 2, which is the beautiful part of being here today, to create a team of organizations, of people, instead of doing this siloed. But as far as what the AMA is doing, to what you asked about helping us get to a better place, mental health-wise and addiction-wise, honestly, the first step of any of this process, I think, is to take a look internally. Right? I think it's reflexive to say, what do we got to do out there? And I think the reality of that has a lot to do with stigma. Right? With a million physicians in this country, you're going to see, I think, a spectrum of recognition, willingness, a sense of responsibility for helping the country with this, right, as the leaders of healthcare and the physician community. And so I think that's something that we focused on, right, to recognize what we think internally, what our reaction is, and perhaps what it should be. And then from there, once we're through that phase of it and have evolved, I think education has a lot to do with it. Like knowing the right thing to do, but not necessarily having the background to be able to do that. For a primary care physician, I can think of a generation ago when I was a medical student, there was some hesitancy for a primary care physician to deal with a mental health issue. Now that's changed. It's taken a big step in the right direction, still a long way to go, but some comfort with the primary care physician treating somebody for simple depression, right? But I think that barrier still exists when it comes to addiction, right? I think we have a longer way to go with that. And this is what the AMA has been working on to be able to learn about the value of buprenorphine, for example, right? In dealing with addiction in a patient in a primary care office, where now you don't need an X waiver to be able to do that, right? I think that's a big step in the right direction. And then finally, I think that the external work that physicians do in their communities, trying to get coverage, right? Dealing with a lot of people that have trouble with insurance, right? And it's one thing to have an issue with a mental health problem or an addiction and even get to the point of being willing to go see your doctor, right? I mean, that itself is a huge barrier. But then to get there and then have to deal with the bureaucracy. I loved hearing that word so much. Not because I love that word, but I love the passion that recognizes that bureaucracy. And then, of course, then there's the long term. What do we do after taking care of somebody's overdose? Right? I mean, you guys do an amazing job in the emergency department. but then what, right? That I call it a warm handoff, right? Not a cold handoff, like, okay, you got this appointment, go see this person. That just ain't gonna work, right? We know that. And so the warm handoff, so that when somebody goes from the emergency department to the floor, to be able to be, counseled on, what the role may be of something like buprenorphine. And then the warm handoff to their primary care physician, right? And not even, if that's going to take 2 weeks because of the shortage that we have of 80 million physicians to 100 not having one, a phone call, right? How are you doing? Your appointment's coming up. That interaction, I think, is something that we are all aware of at the AMA, and that we're working on that continuity of care, that warm handoff.
Great. Thank you, Dr. Mukkamala. Dr. Piccinni.
Piccinni. Yes. Thank you. It's really great that the osteopathic profession has been invited here, and the idea of really the focus of whole patient care, which has been in our wheelhouse for over 100 years. For us, it all starts with the person. We know that there's not enough psychiatrists, addiction specialists, or primary care docs around. So what we've really focused on in the osteopathic profession is getting residencies out in those communities, because we know research shows that where a physician trains are more than likely where they're going to practice for the rest of their lives. One of the headwinds of that is, unfortunately, loan repayment, because we see that younger physicians are making decisions about how they're going to be able to pay their loans. So to be able to keep them in those communities, we have to address that issue. Not only that, the American College of Osteopathic Neurologists and Psychiatrists have partnered with osteopathic state and specialty societies for a great number of years to help their members understand behavioral health diagnosis, management, judicial use of medications, and that treatment, along with partnering with core REMS and using not only the better use of opioid medications and judicious use of opioid medications, but really incorporating osteopathic manipulative therapy, which is a certified non-pharmacological treatment for chronic pain. We know that, we've heard some of your panel before saying that, there's not enough primary care, and we fully agree. But the funny thing is, with osteopathic physicians, half of our physicians are in primary care, and over a third of both osteopathic psychiatrists and osteopathic primary care physicians are in rural communities. So we recognize that that was a need, but we started to see that a lot of those physicians wanted advanced certification in addiction medicine. So our specialty college and our specialty board in addiction medicine reopened a clinical pathway to allow osteopathic physicians, and in this case, allopathic or MD physicians, to become certified in addiction medicine. So it's really coming back to the person and reaching them.
Great, thank you. Dr. Rapaport?
Well,
I actually I'm going to change the question a little bit.
Good.
Yeah. I missed the prompt on my script, sorry about that. From the APA, ASAM, and APA perspectives, you guys have been working in the trenches for many years doing this stuff. And how do you see the partnerships that will come out of initiative that we're kind of working on to really focus on providing the best behavioral health care? How do you see that shifting the practice culture, and where do we go from here? Where does the leadership of all y'all's organizations come into this?
well, Tim, first, thanks for the simple question. But before I answer the question, I wanted to bring up one issue that we need to always acknowledge, and that's the importance of therapeutic relationships. Care pathways are important, and educating folks about the best ways of treatment are important. But if you think about it as a clinician, what keeps people coming back, what keeps people doing the hard work they need to do, be it in recovery or be it from the work necessary to be stable with bipolar disorder or schizophrenia, it's the relationship with the clinical teams and the clinicians taking care of them. And so as we develop care pathways, as we talk about the approaches to team-based care, we always need to include that in that discussion. Now that I've done my message, I'll go back to your question. The American Psychiatric Association is fortunate because we've been able to partner with all of the groups at this table and all the groups at the other tables that we've had today. And that's been really important because, as you talked about, there are 5% of the workforce in mental health are psychiatrists. We need to break down silos. We need team-based approaches to care. We need approaches to care that recognize, as was discussed earlier, the unique specialties that we all bring to the table and the unique abilities that we all bring to the table. And you see that in collaborative care. Thank you, Pat Conway. Thank you for those CPT codes that you developed. Thank you for championing collaborative care. Because that is a way that we're going to be able to reach more patients. But another way that we haven't discussed is peer support. Peer support specialists and integrating peer support into what we do. And this is, again, something that the APA is very much supportive of and involved in, is critical success. So it's collaborative care, it's peer support, it's partnering, as we do also with the CEO Forum that so many of the leaders here are involved in, that we can work together at what's best for our patients and what's best for their families. And that's really going to be critical to what we do. The APA has a large education component, both educating patients and families, educating peers groups, and that's a very much important part of what we do. And in fact, we do it with the AMA. And we have great partnerships there. Thank you for this opportunity.
Yeah, thank you, Dr. Rapaport. I think that, you know, what you said, something that really resonates with me, is something that I really hold as a core belief in that, you know, that addiction is a medical disease, but it's really a spiritual cure. It's a cure of connection. And we can't lose sight of that. And so that's, how do we do that? How do we build that in? It's not, it's not just medicine. Medicines are good sometimes. It's not good, programs and grant, programs, and it's really about connection. And that peer support you hit on is critical. Like, we can't do this without that. It's that connection to family. I mean, that's where the disease lives, is in the darkness of isolation. And so when we shine a light on that, and that's what I think we're doing today, is shining a light on it. And that's, that I get kind of chills when you said that. It kind of reminded me of the core mission of, like, what are we doing? And I felt like a little bit sitting on your couch with a session with you. But I appreciate that, because that's what we do, and that's what all of it, anyways. Dr. Taylor.
First of all, thank you for having this event, and it's really an honor for ASAM to be a part of it. For us at ASAM, this initiative is about implementation. We already have the ASAM criteria, which provides us with an evidence-based framework for matching patients with addiction disorders and general mental health disorders with the level of care that meets their needs, and for defining those levels of care. So the challenge now is to have the implementation, to have the care provided according to those standards that's consistent, a consistent standard for the education of healthcare professionals, a consistent standard for the payers and for the coverage that is provided for patients, a consistent standard for the clinical workflows, and a consistent standard for when patients who have these conditions show up and seek help. So we have an opportunity today, because we've got policymakers, we've got healthcare plan executives, we've got clinicians, and we've got community partners all in the same room. And that's a great opportunity. And so now the thing that we have to do is forge the system together that's going to meet the needs of our patients. I've been practicing psychiatry and addiction medicine for over 30 years. And it still is a gut punch to me every time I see patients, and I come across them all the time, even now, who have fallen through the cracks of our system. Cracks that exist because too many psychiatrists, too many other clinicians, or too many systems haven't really caught on to the fact that addiction care needs to be a shared responsibility. And what I think we have the opportunity to do today is to convert the clinical culture, you talk about the practice culture in this country, to convert that from a culture in which addiction care is somebody else's job to one in which no matter where you are in the healthcare system, some aspect of addiction care is also your job. Some aspect of mental health care is also your job, whether you're in the pediatric emergency room or you're in the elder care facility or anywhere in between. So I just feel like that's the focus that we need to have. Today, we are here and we're going to be making a pledge. But the reality of it is, just like any pledge, just like any promise, it only has meaning if we live up to that pledge, if we actually keep the promise. And how are we going to know whether we've kept the promise? 3 things we got to find out. Number one, and we got to be asking ourselves this as we move forward. Number one, do more Americans have more easy and rapid access to the high quality care that they need for addiction and for general mental health conditions? Number two, once they've accessed that care, are they able to stay engaged in that high quality care for longer periods of time, long enough to reach the point of recovery? And then number 3, once in recovery, is that recovery being supported adequately with all of the various systems that we know are needed to support someone's recovery? If we can answer those 3 questions in the affirmative, then we will have lived up to this pledge, and this pledge will have meaning. If not, we've still got work to do.
Yeah, thank you. Thank you. Dr. Dr. Evans?
Yes, first of all, again, thank you for putting this together. I think it's great that all of us are in the same room at the same time talking about these issues. I think from our perspective, the American Psychological Association, we believe that we need to look at these issues from the perspective of this is an incredible opportunity to rethink, reimagine how we approach healthcare. And I think one of the themes that we've heard so far today is this idea that we have to do it together. We have to have multidisciplinary teams. There is no one profession that can deal with the complexity of behavioral health conditions. And that means that every profession has to operate at the highest level of their license. And I'm glad that there's a discussion about bureaucracy and regulations often that limit people, and we really need to look at that and make sure that people are operating at the highest level of their license. There are a few principles that I think are important as I've listened to this conversation. One of them is flexibility. We've talked a lot about integrated healthcare. The reality is that if you look around the country, even though we've made a lot of progress on integrated care, most of the country, it's just not happening. And we have to recognize that different parts of the country have different needs. If you're in frontier America or you're in rural America, a lot of the things that we take for granted in some of our urban areas just aren't there. And so if we want integrated care in those areas, we're going to have to be more flexible. And so we need to be thinking much more about principles and not being stuck on particular models. So flexibility is one of the things that I think is really important. Another issue, and I'm here as a provider, I guess, or representing providers, but most of my career I was a public payer. And the one thing that I know is that if we really want to change the system, we have to have payment models that get us what we want. We pay for process, that's just the reality. We don't pay for outcomes for the most part. But when we do pay for outcomes, we get really great results. When I was a payer, we talked to our inpatient providers ad nauseum about continuity of care and making sure that people had a good referral when they left treatment. What we heard over and over again was, well, we really can't do anything once people leave treatment. We implemented pay for performance. One of the providers that was at the bottom of the distribution the first year that we did it didn't get any payment, saw other providers, inpatient facilities, get very significant payments. In 1 year, they were at the top of the distribution. And all we did was change how we paid. And so if we want different outcomes, we're going to have to align our payment systems around the outcomes that we want. And that means not just looking at those kinds of metrics, but really looking at how do we set up systems so that providers are being paid for the entire course of treatment. Believe very strongly that we ought to be looking at accountable care organizations and other payment models that really focus on all of the needs that people have. The last thing that I would say is that we have a great opportunity to incorporate technology. Our organization passed a policy around population health, really emphasizing the fact that we can no longer simply treat people after they're in crisis. And you look at most people who access treatment, they're accessing treatment after they're in crisis. We have to get upstream, and that means that we have to look at people and be willing to intervene with people before they have a diagnosis. Because a lot of times when we wait till they have a diagnosis, it's a problem. I think most people agree that we ought to be taking more of a population behavioral health approach. We have to have then the payment models that do that, but we also have to use the technologies that allow us to really do population health. The problem that we have is that we don't have enough behavioral health providers. But with AI technology, we do have an opportunity to do some of the things that people need. I'm not a believer that we can do psychotherapeutic interventions yet, but there are a lot of things that people who have behavioral health conditions need. A lot of those things can be done by technology, and we ought to be looking at how we can use technology to do some of those things.
Great, thanks. That kind of raised a point that I wanted to highlight, and that's, when we talk about prevention, I think our, Western-based medicine, our medicine is based on treatment, so we're really good at treating things. But the problem with that is when we focus on that is that, it's like waiting, we have really good burn surgeons. So, so we focus on that, but maybe we should be focusing on people not getting burned. It's the same kind of thing, where I think that the focus, we need to still focus on treatment. We need to provide the best possible care to the patients that get there. I equate it to almost like a cancer. So you've got someone, you don't want to wait till stage 4 cancer or stage 3 cancer. You want to catch them when they're in stage 1, when you can do minimal intervention, and then they're healed and they're cured. And that's, for me, that's really exciting. One of the reasons that I was willing to, like I said, leave my previous life, sell our house, move out here to do this, and that's to have a change in the kind of the core culture, and going back to the basic principles of human connection. Eat with your family, play with your friends, eat healthy food. Food is medicine. I don't know how many times in the ED I saw people come in who may have high blood pressure and diabetes and things, and they just would want a pill to get. And I said, well, you gotta lose some weight and you gotta exercise. And I would ask them, they come with anxiety, and I'd say, well, what about, can you have like a spiritual connection? Do you have, that kind of thing? Are you connected with your family? Like those things, like your grandma would say, duh, you gotta eat right and you gotta exercise. Those principles, common sense things. I think we can be so much of what we can do. And that's a cultural shift, but there's so much that we can do with that respect that can really kind of get to the root, and that's where we need to kind of like reboot how we view health in the country. So,
yeah, for sure, Tim. You bring up something that's on my mind a lot, and I give in a lot of my speeches. I'm traveling as AMA president, and that's what we call lifestyle medicine, right? And it's simple stuff, 7 hours of sleep, dietary stuff, but one of them is social interaction. Right? And when I think about it, as a head and neck surgeon, those patients that have head and neck cancer, whatever stage it is, they do better when they have good mental health. Their survival is better. Right? And so for us to recognize the intersection. It's not two separate pillars, like we're gonna do physical health, but we're also gonna now focus on mental health. One has an immediate impact on the other. And so I think you bring up a great point that to ignore that and expect better statistics about the health in our country is foolish. And so that's why this is so important.
And that, you know, also that another area I wanted to focus on was the mind-body connection. So there's so much that's tied between, you know, what you're thinking and how your body's working, and that simple shift of you know, doing the things that connect you to your family, connect you to your spirituality. Those things are I'd say are better medicine than a lot of pills are, and that's that kind of the drive that I have is, you know, is pill culture to purpose culture, chemical coping to human connection. Like that's to me that's what it's about, and that's just, you know, those core, you know, core principles.
In the osteopathic profession, our main tenet is body, mind, and spirit, and integrating all three. But I'd like to take us down a little bit different track too for just a second, because I think as being a psychiatrist, the first psychiatrist in the osteopathic profession to reach this level, I think it's important that we don't forget, we've been talking a lot about our populations, but we can't forget about the mental health of our providers themselves and the risk of burnout that we all are facing for the burdens that are put on us. But, you know, if we're not willing to see our own mental health issues, it makes it much harder to accept and deal with the mental health of our patients sometimes. So I don't want to lose sight of that aspect of when we look at how we go forth in this pledge, to really truly incorporate not just the whole person outside the white coat, but the whole person inside the white coat or in the treatment room.
Right. Yeah, that's good.
Well, what you're talking about there really rings true to me, since my lab for the last 40 years has studied the interaction between the brain and the immune system. And I like to say, the mind and the body are connected. That's why God made the neck. But what we also know is that there are many ways of intervening. You can, you know, our psychotherapies and a lot of our traditional approaches are top-down approaches, but there also are possibilities for bottom-up approaches to modulating the brain. There's good data, for example, that shows you can treat GAD with massage. There's data showing you can treat cancer-related fatigue again with massage. There are clear data showing that exercise is important, not just for physical health, but also for mental health. And we see that in anxiety, we see it in depression. So there clearly are these ties that need to be reinforced in any care pathway we deal with. But in doing so, we also need, you talked about the importance of outcomes, others did, and they also talked about the importance of having an EMR that deals with this. One of the problems we face is that most of our EMRs aren't well set up for measuring mental health or psychiatric outcomes. And so we would need to, as part of this effort, change that. We would also need to change the payment model, because right now, if you have a depression that's well treated or bipolar disorder that's well treated, if you're in remission, it's hard to get reimbursed for the same type of follow-up visit that you would have if you were treating somebody with diabetes or treating someone with hypertension, where of course you would check and see how they were doing and check and see if the medicines are correct. But that's hard to get paid for in behavioral health. So if we're going to fix the pathways, that's part of what we have to fix as well. Thanks.
Great, thanks. Dr. Taylor?
So I'm gonna add to what Dr. Rapaport just said. That's also true for long-term recovery from addiction. We at ASAM applaud the fact that this administration and everyone here recognizes that addiction is a chronic medical condition that can be treated and controlled, but typically not cured, and therefore recurrences can occur. right? But what that means is when we get someone into long-term recovery, that recovery needs to be supported. And by the same token as Dr. Rapaport was talking about someone with bipolar disorder who's in remission, or someone with, major depressive disorder that's in remission, same is true for someone with opioid use disorder or with cocaine use disorder who's in remission. That recovery needs to be supported, so that we need to have coverage from our premier coverage institution that provides insurance coverage for people on an ongoing basis, because it is a chronic medical condition, and I think that's something that's really important. I also wanted to pivot to the whole discussion about mind and body. One of the things that I have enjoyed working with my colleagues in ASAM and throughout ASAM is that we're not all psychiatrists. I happen to be a psychiatrist, but the president-elect of ASAM is a medical toxicologist. And we have numerous members who are primary care physicians, who are pediatricians, who are OBGYNs. Why is that important? Because we want to be able to reach people at whatever point in the healthcare system that they might present with a substance use disorder, and we feel it's important for people to be able to get care from someone who's knowledgeable about addiction and about general mental health concerns, regardless of their specialty. Again, we want whatever point that you happen to occupy in our healthcare system, it is, at least in part, at least to some degree, your job to help people who have a mental health condition or an addiction disorder, at least to some degree, to help them with that condition. And I think that underscores the fact that, yes, we are all in different specialties and everything is so siloed. The way we bring it together is by all of us owning this, because we understand that there is a connection, an inextricable connection between mind and body, between mental health and physical health. In fact, mental health is health.
That's great. I want to bring, before I get to you, Dr. Evans, I want to bring one point up. I think one of the things that I look at is the way that we treat addiction, like it's a real disease, medical disease, chronic medical disease, is the same way that we would treat diabetes. So if a diabetic came to us and had been off their insulin and had been eating cookies and came in with a blood sugar of 650, and in the ER this happened, multiple times, the same patient over and over, I never got to the point where I said, I just gave up. I'm like, that's just not going to work for them. I'm not going to, they're insufferable. It's just a homeless drug addict, and there's, it's never about that. I think that's, for me, that, I always felt like, there but for the grace of God go I. So, and seeing the humanity in all of us and in our patients, and building the systems that give them the opportunity to get the care. We would never say, you got 7 episodes of treatment, it didn't work. You're shit out of luck, like good luck kind of thing. And so, and the other thing I wanted to bring up, I think too, is I learned this in recovery, 29 years ago when I went into treatment, is that, there's not a cure, it's in remission. And so while I'm doing this, while I'm in sobriety, while I'm working my program, my disease is doing push-ups, and it's waiting for me to relapse, and it's waiting, and it's going to come back stronger than when I stopped 29 years ago. And that to me is like, that's the reason that we have to build these systems, and then figure ways out that we can continue the care to treat it like every other chronic disease. But, yeah, Dr. Evans.
Yeah, I want to go back to the point you were making about prevention, which I think is so important. I've been in the field for over 30 years, and I think it's probably one of the most important things we can do for behavioral health. So much of our resources, 90%, are on the back end of issues. And one of the things that Dr. Oz said, and then when he's talking about youth and getting screened in schools, and Brian Herpern when he was talking about criminal justice, the reality is that people who have behavioral health conditions, they show up everywhere. And they don't come to us as providers often. They show up in hospital emergency departments, they show up in criminal justice, they show up in the schools, they show up in child welfare. And one of the things we have to do is we have to embed behavioral health expertise in those settings. Not only putting people, but I think one of the things we've even heard on this panel we have to empower other people to be able to recognize these conditions and know how to intervene. Most people don't, and so people languish. And so I think we have to take a more comprehensive approach in the way we look at it. How do we make sure that we are putting services and people in the places where people actually go, as opposed to requiring people to come to us? We know for addictions, only, 20% of people are going to access treatment, and for mental health, it's less than half. And if you're talking about certain groups, it's even a lot smaller. So we have to be a lot more creative about how we're going about addressing these issues, making sure that we're meeting people where they're at, and that we have payment models that are flexible enough to make sure that we're supporting people in that way. Last thing that I would say is and I think we've heard it here again, at the end of the day, we can be very good technicians in what we do, but at the end of the day, it is the personal relationship that people have that really helps. And I've been in programs so often where you ask people, what really helped you to get through treatment? I've never heard anyone say, Doc, it was the paradoxical intervention you did on the 3rd session. They never say that. What they're most likely to say is, well, you call me sir. You call me mister. It's those little things that connect. And I think as we're talking about technology, we're talking about protocols, that we have to make sure that we keep that part into the way we treat people, because that's really what helps people to get better.
I think what you highlight is thinking outside the box. So, the system is the way it is now, and it's the way it's come together. I think everyone, it's not because people aren't trying to do the right thing, but how can we reimagine the system to be what the system could be? What's the ultimate expression of what the mental health system could be? What's the ultimate expression of what SAMHSA could be, or HHS? And I think then try to move towards that goal rather than, we still want to do the best that we can with what we have, but then also an aspirational thing of what can we do, a part of that. So I'm going to throw that back at you, Bobby,
Sure.
is, what's next? I mean, how do we take this kind of moment that we have and the opportunity that we have and go forward?
Yeah, I think that's the critical question. So how do we improve the mental health of our country and deal with those people that are most in need? I think just the very basics, like workforce, right? We need to have a workforce that is big enough to actually solve this problem, as opposed to just drowning/treading water. Right? I think that's where we are now. We need to have that kind of robust workforce. Part of it is when we have that workforce, like we talked about many times, I think it's come up in every panel, the bureaucracy of trying to do the right thing, right? Things like prior authorization for doing X that I know my patient needs, my patient wants, but then all of a sudden we have this barrier. And then, the compensation for doing that work. It shouldn't rely on our morality. That's there. Right? But then physicians suffer what we call moral injury, where we know the right thing to do, but the compensation for doing it and the hassle factor makes it difficult to do. That injures us inside and then leads to our own issues with our own mental health. And that's why I think this is an amazing moment. There's lots that I, as a physician, that we as the AMA disagree with an insurance company on, right? Our mission and insurance company's mission are oftentimes, when you read them, they sound good, but the reality is it's sometimes difficult. But this is a moment for all of us to sort of have the same north on the compass, right? To agree that, yeah, these are our mission statements, but this is our mission, right? To improve the mental health of our country, to get over the consequences of addiction, where we lost 110,000 people not long ago. Now it's down to 70,000 from overdose. But if that's our mission collectively, then we will move together in that. And again, like somebody said earlier, it's not just a signature, right? It's taking this forward and looking at how we think. And every time this comes up, not looking at the mini north on the compass, but the north on the compass to guide us. And that's what I'm excited about.
Awesome. Yeah, and that's exactly what we wanted this pledge event to be about.
With everything that's been said here, I think I agree totally with it. I think one of the other things we need to do as a society is primarily destigmatize what getting mental health treatment means. Too many times when we see a bad occurrence, social media goes down the pathway of they must have been crazy or there must have been a mental health issue. And oftentimes there is nowhere near that. Sometimes there is, but sometimes there isn't. But it sets up a resistance for patients, providers, to get the treatment that they need. So I think some of the barriers are, legislative, the bureaucracy, but also toning down the social media negativity that we see in getting mental health treatment. It should be something that is applauded and honored as opposed to something that is spoken in the corners or in a dark room.
Yeah, that's one of the things I wanted to also work with working at SAMHSA is to focus on celebrating recovery from addiction, from mental health, and from all chronic diseases. And that's, I think, the positive message, and that's what's really exciting to me is that's, the country is divided, but I think we can all unite on, like, we should be better to each other. We want people to be healthy and happy and successful. I think 95% of us have those ideals, and so I think that's really it's exciting to be able to unite around that core drive.
Yeah, I absolutely agree about the need to decrease the ignorance and shame and guilt and prejudice associated with mental health and substance use disorders. And that's why campaigns like Love Your Mind that the Ad Council's done is so important, where there were 5.2 billion impressions the first year. I think the point that Arthur, you were bringing up again, and Tim, you started with, about prevention is critical. The schools are a place for doing this. It's not just a place to assess the child, but rather to intervene with the family as well, and create a community that is pro-mental health. Data from Nina DeLacy has shown that families with kids before the age of 5 can identify kids that are at risk and at risk of developing externalizing and internalizing disorders. We need to intervene early with families in terms of education, in terms of breaking down stigma and saying, hey, we're not criticizing you as a parent. What we're doing is working together with you so your child doesn't get anxious and depressed. So preemptive interventions or preventative interventions are important. Preemptive interventions are great. Ed Craig has developed a program that's in Iceland, it's in Portugal, it's in Sweden, it's in Greece, where they can identify kids at age 10 and 12 that are at risk of developing a depressive disorder, and with a 3-month intervention, it's a therapy intervention for 3 months, they decrease the risk of converting into a mood disorder by a factor of 8. The other thing that's very important that we talked about is it's not just looking at symptoms, it's looking at quality of life and functioning. And it's ensuring that if we're going to look at outcomes and results, if we're looking at value, that's part of the value as well. Thanks.
Thank you.
So I've been sitting here and listening to my fellow panelists here, and I heard my friend and colleague, Dr. Mukkamala here from the AMA, quote the statistic that so many of us have focused on and have been aware of for a long time. The fact that we went from a high, an unconscionable high of 110,000 overdose deaths in this country to where over the last couple of years there's been an improvement to 70,000 overdose deaths in this country. And I think everybody in this room can agree that 70,000 overdose deaths in this country is still absolutely unacceptable. And I think so when we talk about where we go from here and what do we do about stigma, I think there are some things that ASAM's been prioritizing that are attempts to really operationalize destigmatization of addiction care. For example, we have a medicine that we know can cut down the death rates from overdoses from opioid use disorder by at least 50%, and that's methadone. And so we need to, one of the things that we're going to be working on is trying to make sure that people have access to that medication and any other medication that is evidence-based, that has the ability to help people with addiction disorders to be able to live longer, to stay in recovery longer, and therefore get those recovery outcomes that we talked about earlier. So that's one of the things we're going to work on. We're also going to work on the fact that being a senior who has an addiction disorder should not be something that works against you. So Medicare needs to cover the Recovery Act for seniors so that a senior can get residential addiction care that is evidence-based, that also takes care of the co-occurring mental health conditions that they have. We shouldn't have the fact that you're a senior citizen in this country mean that your Medicare doesn't cover the treatment that you need at all levels of the care continuum. And then finally, the last thing that we really want to make sure that we emphasize is that we have to have people who can get access to addiction care, quality addiction care, regardless of your zip code, regardless of your ability to nimbly negotiate fragmented care systems, and regardless of what kind of insurance coverage you have. People need to be able to get access to high-quality care without any of those factors being determinative of their access.
You know, what I'm hopeful about is I think we're at a really critical point where we really are starting to rethink how we approach our work. We know what helps people to stay psychologically healthy. We know that. We have years of research of that. We know how important social support is. We know how important behavioral activation is. We know these things. The problem is we've never used them in a systematic way. You know, Mark's point about early intervention. You know, if you're a family member and you have someone in your family who has either an addiction or a mental health, a serious mental illness, you know when they're about to go into crisis. But if they don't have a diagnosis, they're not going to get treatment. We know that that's a problem, and so we really need to question some of the fundamental ways that our systems are structured that keeps people from getting the help that they need when they need it. And we ought to be using the science that we have available to address those things. So I'm hopeful that what we can do going forward is to really rethink. One thing is really sure. If we do the same things, we will absolutely get the same results. If we want to get different results, we're going to have to radically change how we're coming at healthcare. And so I'm very excited about that, and I hope that we can use technology because for the first time, I think, certainly in my career, you can see a possibility where through the use of technology, we can actually reach people, not to replace us, but to enhance us, to enhance our ability to reach people. And I really hope we can really embrace that because that gives us an opportunity to reach people that we've not reached before, to reduce suffering, and to ultimately improve the overall health of people.
That's great. You guys, I really thank you so much for coming out here. Thank you.